So I am going to start again. Let me go back up a slide. And once again, we're talking about pressure ulcers, stage 2 to 4. There are 3 different quality measures on the set of quality indicators that are used, and these are the 35 quality indicators that we find at the different ministries. That's CIHI on the federal reporting, as well as the Health Quality Ontario Gold Standards. So we'll be looking at all of those. Now, 3 types of measures. We're going to be looking at a prevalence measure. That is, do you have a stage 2 to 4 pressure ulcer? Now, please remember, it's a pressure ulcer that we're looking at. None of the other ulcers that come from section M1 are recorded. We're looking only at M2A item on the MDS. And so if you have a stage 2 to 4 ulcer recorded there, then you will trigger this quality indicator. We're also looking at worsened ulcers. That is, if you have a ulcer and a worsened stage 2 to 4, always keep that 2 to 4 part in mind. So if you had a stage 0 or stage 1 on the prior assessment, and now you have a 2, 3, or a 4, then it's a worsened stage 2 or higher ulcer. And new ulcer. And now remember, it doesn't mean a new ulcer. I know it says new ulcer, but what it actually means is a new stage 2, 3, or 4. So it's a new stage 2, 3, or 4. So obviously, what does that mean? That means on the prior assessment, you either had a stage 0 ulcer or you had a stage 1. Now you have a 2, 3, or 4, and it's a new stage 2, 3, or 4. Okay? So let's now just go to the next slide, and we're looking at indicator types. The first indicator types are prevalence indicators, and we're going to be talking about those today. We only need one assessment, the current assessment. We don't care what happened on the assessment 92 days ago. Then there are the incident indicators. That means we're going to have 2 assessments because we need to look at the current assessment and then look back at the prior assessment. And those incident indicator types come in 2 flavors. We can look at where you've actually increased in your functional performance or you've decreased in your functional performance. So improvement indicators and decline indicators. Now, the prevalence indicators, where we're just using the current assessment, have some exclusion factors involved. First of all, the assessment was carried out 92 days after the admission date. So when you fill in the data for admission date AB1, then you know that this assessment must be carried out more than 92 days from that admission date, so 93 days in the building. The assessment cannot be an initial full assessment, or what they call a type 2 assessment. I'm sorry, a type 0-1 assessment, the initial full assessment. So those are not included on the reporting period. And only the last assessment in a quarter is used. So if you had a person who had their quarterly done in January, but in February they had a significant change assessment, where they're only going to use the significant change assessment. That quarterly assessment is not included. And you also may know that you can do as many assessments as you wish. I mean, there's no limit on that. So if you wanted to do several quarterly type assessments or several full assessments in a quarter, again, it's only going to be the last assessment that's going to be looked at for quality reporting. Now, on the incident indicators, where there is a look-back assessment, once again, the first 3 criteria apply, just like it did for the prevalence indicators, but there's one more criteria. That assessment in the previous quarter has to be at least 45 days ago. So it cannot be less than 45 days between assessments. But it cannot also be any more than 165 days ago. So the 165 days are going to be pretty simple because you know that there's a 92-day window. And so as long as you've got something that's under the 165 days, then it can be used. So those are the prevalence and the incident indicators. Anyone meeting one of those criteria will not be included in the report. So do not be surprised if you said I had 110 people the whole term, the whole quarter. However, I'm only showing 100 people on a report. That's because there are certain criteria that they're going to have to meet. Now, there are other exclusion factors, but those are indicator specific. So we'll look at those when we look at the actual indicator, what those exclusions are. But these exclusions apply to every assessment. I'm not going to cover population risk adjustment. However, you know that when you look at the CIHI reports or your ministry reports that come to you on the quality indicators, there is what's called a population risk adjustment number, and then there is an unadjusted number, and you can get both types of reports from CIHI. I'm always recommending that you look at the unadjusted numbers because they're going to have more interpretive meaning to your staff. However, if you want to compare yourself to other nursing homes, then you're going to want to use the population risk adjustment. And so what is this? These are factors beyond the facility's control that could affect a given outcome. And I'm just quickly, let's say that you had a higher than average number of people with dementia, a higher than average number of people who had new medications or antipsychotics or psychotropics of any kind, then you could expect that you may have more falls than the typical home, simply because you have more people who come to your home who are at risk for those things. And initially those factors are not within your control, so we don't want to penalize you because you have a higher fall rate. The same is true for the reverse situation. You may have less than the average for some indicator, such as age, dementia, things of that nature, new medications, and then you should experience less falls than the average. And so once again, the population risk adjustment will either penalize you if you have a simpler population to care for, or it may reward you on the quality indicator if you had a population that was more severe or higher risk than expected. So that's what the population risk adjustment does. Now on the very last day when we do the last indicator, the 35th one, I'm also going to do another half-hour session, and I'm going to give you an example of a population risk adjustment for those who want to know that type of information as well. Now, one thing also that's very important is the idea of a rolling 4 quarters. When you run a report at CIHI or you get a report from the ministry, you're going to see that it might say 2017 quarter 1 on the report. Please remember always that that's 12 months of data. So it's not just what happened in your home in that quarter. It's what happened in that quarter and the preceding 3 quarters when we're looking at the prevalence indicators. So it's very important that we understand that. So if you've suddenly said, boy, we put a great program to prevent falls, and I know that we've cut falls in half this quarter, you're not going to see that cut in half this quarter immediately, because you still have the fall rate from the preceding 3 quarters or 9 months. So you have to work your way through that. And it's called a rolling 4-quarter average, but all that means is you're being recalculated across 12 months of data for every single quarter that they report on. Now, a rolling average for prevalence indicators, and specifically, and you can see here I'm showing you 4 different quarters. And then here's the current quarter. And we're looking at 2014 quarter 1. That's the report that we're looking at. And it tells us we have a 15% fall rate. Please remember that includes the data from quarter 4, quarter 3, quarter 2 are included in this particular report for quarter 1. So that's the concept. So if you had 100 residents, you would not be surprised to see the number of residents to calculate that statistic is 400 plus. So that is very possible. Okay. Now that's for where we're only using one assessment. When we're using 2 assessments and we have to do the look back for either improvement or decline, we have to bring a 5th assessment in, and it's shown here in yellow. Now, it's not part of the number of residents shown for the report. This one shown in yellow is simply a look back for the quarter here. So in 2013 quarter 1, we had to look back to a prior quarter. So that assessment is being used as well. Okay, so you can see it's not just a simple matter of changing things within a particular month or a particular quarter. We're looking at how we're going to feed this information or changes through the entire system. Now, one thing I do want to mention, since everybody's on mute and just given the number of people that are in the seminar, and I just want to mention that there is a chat box there where you can leave questions. If you leave a question, then Heidi will compile them, and then she'll send all the questions to me, and then I'll answer them and email them back out to everybody in the group. Okay, so just remember the chat. Let's begin looking at the different indicator sets that we're going to be reviewing. And I'm going to go through these same review slides each and every time. You know, we always have new people come one week and people not there another week. So we need to continue to review them. There are 12 prevalence indicators. Remember, prevalence means we're only using the current assessment. You either have it or you don't have it, period. The 2 items that we're looking at today are new 2 to 4 ulcers and the fact that you have an ulcer. Now, obviously, you can see here it's new ulcer or you have an ulcer, period. Now, here you can see that none of the ulcer indicators are part of what are called the improvement indicators. And then there are 14 decline indicators where they're measuring decline in status for a particular individual, either functional status or their medical condition. Now here we're looking at worsened stage 2 to 4 ulcers. So those are the 3 different indicators that we're looking at. So once again, we have 12 prevalence indicators where we just use the 1 assessment. We have 9 measures of improvement in health status, and we have 14 measures of decline in health status. And we're looking at those 3 that all deal with item M2A from the MDS. Now, before we move on, I just want to review a little bit of something for you here. And you can see here I've listed out some of the indicators. I've listed out 13 of them. And on these 13 indicators, you can see I'm showing you what the gold standard is that was set by Health Quality Ontario. And so if you look at the worsened ADL score, that worsened ADL is the one that measures the the early loss ADLs, the mid-loss ADLs, and the late loss ADLs. So there are 7 items altogether, and it can be scored from 0 up to 28. You see here that Health Quality Ontario has said that they want to work towards a benchmark of 25%. And in the most recent data from Ontario, 2017 quarter 1, you can see that the current status is 33%. So they're still working towards that goal. There is also a RAP that's related to ADL, and it's called the ADL Rehab Potential at RAP number 5. And we'll see also that there's a CAP related to ADLs as well, and we'll look at both of those. So my goal here today is to not only just show you the quality indicator and what items, but to also show you how it impacts the risk indicators, the RAPs or the CAPs, and then how that impacts funding. So we're going to look at these pressure ulcers and see what is the role or the implication for pressure ulcers. Now the next item I want to show you here is sensitivity. That is Carol Estabrook, and you can see the reference here at the bottom, and company from the University of Alberta conducted a study in which they looked at the 35 QIs from the MDS or the CCRS, depending on how you term it, and they said, which of these items can nursing care have the most impact on? And so what we're looking at here is for 2 of the measures from the health quality, where there's a 1% goal set for both the worsened and new. You can see currently in Ontario it's 3 times that for those, so they're working towards this 1% goal. But you also see that under the Carol Estabrook paper that they're saying that ulcers, pressure ulcers, stage 2 to 4, are the #1 area that nursing care can impact. So I think that's a very good one to look at, one that'll help you to decide if you're going to look at what areas are we going to measure, where can we have real impact. So you see worsened pain, there is no quality measure for it. It's just about 10% of residents experience worsened pain. And you can see here it's the #2 area that the Estabrook et al. Say that we could have impact on. Okay, so let's move along to the next slide. So we're going to look at pressure ulcers. And we see from the MDS form under section M that it's M2 that we're looking at, and it's only the A part, pressure ulcers. We're not looking at stasis ulcers. And so that's the item, and I've just blown it up here on the side so it's just a little more clear. So pressure ulcers, any lesions caused by pressure resulting in damage to the underlying tissue. Okay. Now let's move on to the 3 different indicators and how they're calculated. So the first indicator is residents who had a stage 2 ulcer. So we're only using the one assessment. And all we need to see here is that item M2A on that current assessment is either got a 2, 3, or a 4 recorded in there. And that means that to trigger the indicator, we have to be at 2 or higher on the staging. So there are no other exclusion factors. We know already about the exclusion factors, the general exclusion, but there's no specific exclusion factor for this ulcer, or for this indicator. Now the second indicator is stage 2 to 4, where there's been a decline or a worsened ulcer than before. And if on the prior MDS and the current MDS, we're looking at M2A, current indicator, stage 2, 3, or 4, pressure ulcer, M2A greater than or equal to 2, and M2A on the current is higher than what it was on the prior. Notice it has to be 2, a new 2, 3, or 4, and here it's got to be higher than whatever those stages are. Okay? Now there is an exclusion, and that is if on the prior assessment you had a stage 4. And that just simply is obvious that if you already have the highest stage, you can't get worse than that. So these people would be excluded from this calculation. The last indicator is residents with a new ulcer. And here we're looking at the prior MDS and the current MDS. And the current MDS, right, a stage 2, 3, or 4 pressure ulcer, right? And then on the prior, you were 0 or you were 1. So remember that thing what I've said here, warning, or should say warning, MDS codes no ulcer as a stage 0 ulcer. And I've got to check my spelling. So please look at this one example that I have here on the side. If your prior assessment showed 0, 1, 2, 3, or 4 on the first prevalence of stage 2 to 4s, and your current is 2, 3, or 4, then you will trigger. Okay, so that means all we want to know here is it's really relevant what you had on the prior assessment. Now for the next indicator where we're looking at decline, you can see the prior could be 0, 1, 2, or 3, but now you're a 2, 3, or a 4. Okay, so as long as you're higher, then you've declined. And then obviously if you can't be a 4 on the prior because you'd be excluded. And the last indicator, if the prior assessment was a 0 or 1, and now you've got a 2, 3, or 4, then you're going to trigger. Please notice that for some residents, all 3 of these measures could be triggered all about the same ulcer. Okay, it was 0 before, that, and it's a 2 now. Well, obviously, that's having a 2 right now. It was 0 before, and it's a 2 or higher now. Obviously, that's worse. And if it was 0 before, and now it's a 2 or higher, then obviously that's what they're calling new. Okay? So we need to understand that it is possible for one resident who did not have an ulcer on the prior assessment to actually end up triggering all 3 of those indicators. So we've looked at the indicators and how they're calculated. You can see it's a very, very simple calculation. If you're using the RAPs, what we want to know is what risk are you in with respect to ulcer. And you can see there is a pressure ulcer RAP. Now for the RAP, it's either triggered or not triggered. For the CAP over on the right-hand side, there are 4 different levels of trigger. So it's not triggered, it's triggered, that is you have a stage 2 or higher ulcer, okay? It's called a 2 trigger, has a stage 1 ulcer. A 3 trigger does not have an ulcer, but they have risk factors. And we're going to look at these just very quickly. Now at the bottom here is the actual calculation. So if you're looking at the RAPs, it's saying if the pressure ulcer is a stage 1, 2, 3, or 4, or bed mobility, transfer, toileting, and eating are scored, right? You can see them here. Or H1A, and H1A we know is the bowel, and it's scored as a 1, 2, or 3. Or item I here, peripheral vascular disease, or M3, which is a history of resolved ulcers, or M4E equals 1, that is the skin desensitized to pain, and P4C is equal to 2, which is trunk restraints. So any one of those factors will put you and trigger the RAP at a value of 1. The RAP will be triggered. Else you'll just be a 0 if you don't have one of those factors. Now for the CAP, it's slightly different. You can, let me go back up. For the CAP, we can see here that if your M2A is greater than 2, then you're going to have a value of 1. So, and you can see 1 means has a stage 2 or higher. Else, if your M2A value, your pressure ulcer is a 1, then you're going to trigger here at a value of 2 for the CAP, and that has a stage 1 pressure ulcer. And then here, if you've got any of these risk factors involved, that is you have the, there is no ulcer, M2A is 0, there is no pressure ulcer, but you can see here that bed mobility is totally dependent, transfer is totally dependent, or H3D is indwelling catheters, yes, or M3 History of resolved ulcers is a yes. M2B is greater than or equal to 1, and notice that M2B is the stasis ulcer. Or M5E equals 1, that is, you are receiving ulcer care. Then you're going to trigger at the level of 3, and that does not have a pressure ulcer, but has a risk factor that could contribute to that person having a pressure ulcer. So you can see the RAP and the CAP are very similar in their risk profiles, and we know that when we've triggered these risk indicators, that some action plan or care plan has to be put in place in order to offset them. Now, just in closing, let's have a look at how this one item, M2A, pressure ulcer, okay, at stage 3, 2, 3, or 4, how does pressure ulcer impact our funding? And what you're going to see here is that if you have a pressure ulcer, M2A, now any stage, now here it's got to be a 3 or a 4, okay? So if you had a 3 or 4 pressure ulcer and you have 2 treatments in place or more, and these are the treatments here, the usual from M5A, if you have that, then you're going to be classified into what's called the special care group. And that's this group right here, the special care group. Now remember, you could qualify for special care, but you've got to be ADL dependent. That is, your bed, eating, toileting, and transfer total score has got to be at a level of 7 to 18. Okay, so 0 to 6 won't work. You can't stay in this group with the 0 to 6. If you do qualify because of a stage 3 or 4 pressure ulcer, then you see here it's your ADL score that determines how much funding you're going to get. So if you have a low ADL 7 to 14, you're going to be in the 20th highest funded group. Remember, there's 34 groups altogether if you're in a nursing home, and there's 44 if you're in a hospital. Now, if your ADL score, bed, eating, toileting, and transfer, if your total score is between 15 and 16, then you're in the 19th highest funded group. Or if your ADL score is at the top end, 17 to 18 on that bed, eating, toileting, and transfer, then you're in the 18th highest funded group. So notice how not only your condition that you have classifying you into a funding group, it also depends upon the level of dependency for ADL. And you're going to see that ADL impacts every single funding group. So bed, eating, toileting, and transfer, those late loss ADLs are just so essential. So once again, we're going to end it right there. We're a little bit over. And we're going to please leave any questions that you can in the chat. If there's anything that you're unclear about, if you're not sure how to get this presentation, there is a slide on the web page, and I believe that instructions were given, so you can go to that link and get a copy. If you're uncertain about how to do that, please contact Heidi. And it's just HAYDEE at medi-care.com. So Heidi at Medicare. And you also have it as part of your handout that you were given as well. So any questions, please contact Heidi. I will respond to all the questions and send them out to the group. And then we're going to carry on next week with our next set of presentations. Thank you all very much. Great to see so many people out. Bye-bye.